I think it's 5 after, so we'll go ahead and come together and get started. I'm Christian Verkler, co-director of the program in clinical ethics at the Center for Bioethics and Social Sciences in Medicine, who sponsors our monthly bioethics grand rounds. We're really lucky today to have Susan Gould speak to us about something that she's an expert in. Professor Goold is professor of internal medicine and health management and policy in the School of Public Health. She went to University of Colorado for undergrad, and then she came to Michigan and spent a lot of time here. She did her MD here, got her MHSA in health management and public policy at the University of Michigan, spent some time at Michigan State and got another master's degree in philosophy. She did her residency in Pittsburgh and also did a fellowship here in health sciences research. She's a recipient of numerous awards, too many to recount, including, though, several grants from the Greenwall Foundation and the National Institutes of Health. She was recently the chair of the American Medical Association's Council on Ethical and Judicial Affairs, and she's a fellow at the Hastings Center. Her project, CHAT, Choosing Health Plans Altogether, has also won numerous awards and has had significant impact in public policy drafting. And she currently, for the medical students in the group, she's the director of the new health policy Pathway of Excellence. So join me in welcoming Dr. Gould.
That was longer than it's supposed to be. So I'm going to talk about something that I don't know if I'm actually an expert on ethics and accountable care organizations, but certainly given some thought to issues of particularly trust and trustworthiness and healthcare organizations, healthcare institutions, and that's kind of what we're going to talk about today. So just to make sure we're all kind of starting from on the same page, if you will, an accountable care organization is typically a network of doctors and hospitals that shares financial and medical responsibility for providing coordinated care to patients in the hopes of limiting unnecessary spending. In other words, accountable care organizations, like some managed care organizations, are both providers of and payers for healthcare. So Medicare ACOs have sort of hit the national scene, if you will, and there's two different kinds of accountable care organizations for Medicare purposes. An ACO for Medicare cares for more than 5,000 beneficiaries, and they can unite and form an ACO and potentially get what they call shared savings. Type A, not the type A of, personality stuff, but like Plan A, okay, type A plans, they can share the savings, but they don't have any risk involved, no financial risk involved, if their expenditures are higher than the benchmark that Medicare sets. In the type B plans, they can share a greater portion of savings, but they also share some financial risk. They have a risk of having to pay back some of Medicare's losses if their expenditures are higher than the benchmark. So both types have to report and meet 33 national quality measures. Now, I want you to note that there are other accountable care organizations besides the ones that Medicare supports or funds or recognizes, but that would be useful to start with this sort of more detailed description. But I want to talk about accountable care organizations more generally. Again, both providers of and payers for healthcare for some kind of defined population. In the case of Medicare, it's the Medicare beneficiaries, but it could be other populations for other health insurers or communities. So what does accountable mean? Accountable means, according to Merriam-Webster, subject to giving an account, answerable, capable of being accounted for, explainable. Pretty sure the first one is more applicable to accountable care organizations. In care, again, many definitions of this, but for accountable care organizations, really painstaking or watchful attention, regard, coming from desire or esteem, not sure about that one, charge or supervision. And in fact, the example given in the dictionary is under a doctor's care. So this would be under an ACO's care. An organization is an administrative and functional structure. This could be a business or a political party. Not sure how organized that is, but also the personnel of such a structure. So an organization includes the structure and the personnel both. So let's first talk about accountability. What is accountability? What kinds of accountability are there? There's personal accountability. Okay, this guy broke grandma's window there, has to go up and apologize and admit what he did. That's one kind of accountability. Organizational accountability, I couldn't find any cute cartoons for that one, so I just have some other kind of pictures. And professional accountability, which I think a lot of us are used to in healthcare organization because as clinicians, we have professional accountability primarily to our patients, but also to our professions, our colleagues, and our communities. There's political accountability we're not really going to touch about, it doesn't apply here, and mutual accountability, which has to do with more international stuff. So, personal accountability, I love this one. I used to have a problem with it until I realized it wasn't my fault. Yeah. So personal accountability, again, is taking responsibility for your own actions and behaviors, sweeping up your own doo-doo, if you will, admitting to the broken window. Professional accountability, trust me, I'm a doctor, is a pretty famous kind of phrase, acknowledges that moral obligations of, I would say, by the way, not just physicians, but I have to say I've given this talk to groups of doctors before, so if it's biased toward doctors, I apologize. Moral obligations of clinicians arise from power and status as professionals and the vulnerability of patients. So relationships with patients are inherently imbalanced. That means there are moral responsibilities for the clinicians to seek and to deserve trust from the patients. To seek and deserve trust, you have to be honest and open. You have to use your discretionary power. Whether you're a nurse or a doctor, you have discretionary power over your patients to some extent. No patient can get an antibiotic without a prescription from a doctor is just one example of that. To seek the patient's good, to use your power on behalf of patients, to seek excellence, competence, and knowledge and skill, treat patients respectfully, and there's lots of other things. There's whole books written about trust and clinical relationships with patients. Patients also have some moral responsibilities in a trust-based relationship. For example, to be truthful, to trust wisely. We're not going to talk about those as much. So, but now we're talking about organizations, accountable care organizations. And what this means is that there's a collective moral responsibility. So it's not just about, Dr. Smith or Nurse Jones, but also the organization as a whole, including but not limited to the clinicians who work there. Organizations are moral actors in modern society. Corporations, schools, hospitals, health departments, the AMA, all of these are moral actors. They can take moral actions in society. And their identity is distinct from just what all the people in them do. Okay? When people think about, I was going to say University of Michigan Health System, but now I'm going to say Michigan Medicine. Okay? They have a sense, a relationship sometimes with the organization that is not just the same as the relationship they have with Dr. Verkler or somebody else who's working in this organization. Organizations also act intentionally. So it's not just the individuals in them who make actions, but they do actions themselves. There are strategic plans and policy changes and things like that that are organizational actions. And there are internal decision-making structures and processes that lead to those actions. Some of those actions create role expectations that also have moral content. So they have expectations, for example, doctors and nurses, who are supposed to be patient advocates. Administrators are really more supposed to maximize efficiency or make sure things run smoothly or that, things are organized well, et cetera. Organizations, including, but not limited to accountable care organizations, coordinate and even subordinate actions and intentions of individuals. So the whole idea is that it's not just what this doctor, this nurse, this social worker, this psychologist, this clerk does, but how they all work together to take care of a particular patient or population of patients. And of course, organizations respond to social conditions, including but not limited to the marketplace. They also have a normative structure. The mission statements, the goals, values, and norms, which may or may not reflect the mission statement, are also part of the collective moral responsibility of an organization. So who are they accountable to? That was really bad grammar, but I'll say it anyway. Who are they accountable to? And this one I'm going to ask you. I would wonder, but the little thing wouldn't fit, so I have to stand right here, but I still want you to answer the question. Sorry? Each other. Each other? Okay, so accountable care organizations are responsible to each other? To what? No.
As far as maintaining the standards.
Okay, so they have expectations about maintaining some standards. Okay?
Patient populations they serve.
Accountable to the patient populations they serve. Okay?
Their funding source.
Right? Wherever the money's coming from, follow them with the money. Sorry?
Their employees.
Employees. Michael, is that you in the back? Who else are they responsible to or accountable to?
Society at large.
Right. Or their communities, perhaps? Oh, yeah. I don't know what his dissertation's on, so, okay. Anybody else? Yeah. I would say let's think of both right now. Obviously, since this is bioethics grand rounds, we're more concerned about what should happen. Are there any of those parties to whom we said accountable care organizations should be accountable, or we think they should be accountable but they're not? Are there any that we think they are accountable to, but they shouldn't be?
Let's acknowledge the power inequality, they are huge.
I'm sorry, what?
The power is the inequality of power, they are huge. The people that they should be accountable for are individual and small. Are they congregating and gathering the kind of power to be at the table in the same way? That's a good question.
Okay, so you're pointing out the imbalance of power that I talked about with clinician-patient relationships, but obviously is also true relationships between healthcare organizations and communities and patients, potentially employees, right?
There's no union in the balance, the union of community members, the union of patients of this kind or that kind, the union of taxpayers, the union of there's no.
Now, one exception to that might be the payers, right? So you'll often hear from healthcare organizations or insurers themselves that, I just got to do what the employer wants me to do or the payer wants me to do, because otherwise I won't get the business. So that could be an exception to that. So I would say accountability depends a little bit on the role, but in the case of organizations or individuals who provide healthcare, pay for healthcare, or have some combined function like this, they can be accountable to patients and their loved ones, family broadly defined, not just biologically defined, okay? Potential or future patients. So in other words, Michigan Medicine is accountable to the patients that currently has, but also has some accountability to people who might show up tomorrow, next month, next year, or even 10 years from now, right? To have what they need to be competent, to be available, et cetera, okay? Employees and professionals who work within an organization, especially healthcare professionals, to the community, to payers, again, follow the money, and to society. So that's accountability. Comments? By the way, anytime you have a comment or a question or whatever, just raise your hand, and I don't mind being interrupted at all, so, okay. As an interrupter myself on a frequent basis, I'm happy to be the recipient, okay. So, accountability, care. Care is an attitude or an activity directed toward another object, in this case, patients, toward sentient human beings. So, and that makes it intrinsically morally valuable. If you care for a person, okay, whether that's as a parent, as a nurse, as a teacher, as a doctor, whatever, that is a moral activity. It can't not be a moral activity. The elements of care are to recognize needs, to be sensitive, to be attentive. They call us attending sometimes for a reason. We're supposed to be attentive, not just show up. That's a different version of attending, right? There's a responsibility to take care of those needs, to have compassion, and competence. We sometimes don't give enough attention to the competence both of organizations and of individuals when it comes to trust-based relationships. So accountable care, accountable to multiple parties, so not just to patients, not just to payers, but a spectrum of different parties. Accountable care organizations care for patients, and because of that, and because of the imbalance of power that our audience member, whose name I should know, alluded to earlier, trust is in that relationship. Trust in the organization, not just trust in individuals. So that is the moral foundation of accountable care. So, wait a minute. How do you trust an institution or an organization? What does that mean? How is it different from trusting a person? So sometimes I ask questions rhetorically. Sometimes I ask questions because I want you to talk.
It's how all the interactions are interfaced with the patient or the employee. So if a patient has a good relationship and trusts their doctor, but they can't find parking, or the checkout pharmacist is rude, or their prescription was lost, or 100 other things that can go wrong, then they still love their doctor and trust them, but they don't trust the institution.
The organization, right. So it's a broader experience, a fuller experience that colors how they, or whether they, trust the organization. So let me ask you something to sort of build on that a little bit, because, okay, patient loves his or her doctor, trusts his or her doctor, and the doctor forgets to call him about something, or makes a mistake, or, not a life-threatening one perhaps, but do you think that trust automatically goes away? Okay, so it depends how it was handled, all right.
It probably also depends on whether they trust their institution, because if they've had a lot of bad experiences and now suddenly their doctor is
Doing it too, yeah.
too, then that could play a factor.
Okay, straw that broke the camel's back, okay.
If you have trust in a relationship and it's an ongoing one, I think there's room then for recovery. You might actually want to continue to enter into that relationship to see if you can recover, regain trust. Those are the things, the mistake is made versus if you don't really have a relationship and you have only one experience of that person
Right.
or that institution to base your understanding about how you're treated or trust. You know, like not go grow the trust with one continuing relationship. I don't know if that makes sense.
No, it does, actually. It's, because if you have an ongoing relationship with somebody and they screw up, okay, you can forgive them. They're human. You can recognize they're human. And this, we know this actually from looking at how patients respond to, you know, medical errors, medical mistakes. You know, yes, doctors and nurses, they're only human. They can make mistakes, but it's about sort of how it's handled. And if it's, you know, covered up, swept under the rug, or openly acknowledged and talked about and apologized for, then it can actually potentially even strengthen trust and not necessarily undermine it. So, how might that be different for an organization than it is for an individual?
They just assume the organization is broken and that this is like a pervasive problem, like full-day follow versus one person's individual responsibility and apologizing and fixing.
Okay, so they might see it as more of an organizational sort of systemic problem. I saw a hand in the way back there, yes.
It's partly the same thing as what you were saying to the doctor.
Uh-huh,
That if there's a history of honesty and transparency and clarity around things,
uh-huh,
and a mistake is made, but the organization is transparent about it,
uh-huh.
then the organization may maintain and enrich trust just the same as the individual doctor. And this is explained extensively in David Brin's book, The Transparent Society.
Mm-hmm. Thank you. That was great. I would say it's not quite the same as it is for individuals, and I'll get to that in a little bit because, yeah.
I think one point of difference is just the lifespan of organizations and the fact that history comes into play, cumulative experiences
Right.
that have of the organization and what its presence has been like historically
Mm-hmm.
for a community. We're talking about collective consciousness
Mhm.
and community experiences.
Mhm.
Goes back a much further way than individual interactions.
Okay, so there's history, cumulative experience, and that holds true for interpersonal trust as well as trust in organizations or institutions. I would argue that there's a higher expectation of not perfection, but competence for organizations than for individuals. Okay? Not that there's no expectation of competence in individuals, but there's a certain amount of sort of checks and balances when you're talking about what an organization does and what kinds of actions happen as opposed to an individual. So, let's see, what did I actually have on the slide here? Okay, so provider organizations are entrusted with the health, well-being, treatment decisions, and information of patients and potential patients. And this leads to these expectations of competence. You should know what you're doing. You should have systems in place for doing it well, okay? Also, beneficence, that you're out for the good of your patients and future patients, confidentiality, and some other expectations as well. For payer organizations, there's slightly different expectations. Payer organizations are entrusted with pooled limited resources and the financial as well as personal well-being of individuals who are confronting illness and especially catastrophic illness. So they're trusted to fairly and prudently use those resources to benefit their covered lives, population to whom they are accountable when those resources are needed, not just wanted, but needed. Now, an accountable care organization, of course, is both. And that can cause problems. Healthcare institutions are also places where healthcare professionals work, and therefore there's also this responsibility or expectation that clinician-patient trust-based relationships will be safeguarded, promoted, not undermined. And they are employers, hence accountability to employees. They are also the result of profound social investment, okay? Not just the fact that they're not-for-profit institutions oftentimes, and therefore have a responsibility to provide some benefit to the community or the society to maintain that tax-exempt status, but also hospitals, medical schools are the beneficiaries of lots of social investment from government bodies, also from sometimes private organizations and donors. So what are some of the challenges to trust in ACOs? And I'm primarily going to focus on trust on the part of patients and potential patients, and not so much on the part of like employees and clinicians. You'll see a little bit of that in here, but it's mostly about patients. So one major challenge is that sometimes the organizational interest and the patient interest are not aligned. So, for example, what if something could be a little bit better for this patient, but it's a lot more money? Okay? Remember, the organization has a responsibility to fairly and prudently use resources, and also a responsibility to benefit and care for patients. So that's a challenge. What about persuading a patient to have some kind of a quality measure done when it's really not something that's going to benefit the patient? Okay? Has anybody ever seen this happen? Raise your hand. Give me an example. HMOs. Okay, you have to explain that a little bit more.
Just the alignment of organizations, the provider organization with payers,
Uh-huh.
patient, and against the patient. I think that's sort of reminiscent of what happened.
Okay. I'm looking for an example of a quality measure being done to meet a quality measure, basically, and not necessarily because it's the best thing for the patient.
Follow-up CAT scan.
Follow-up CAT scans, okay. Anything else? Oh, in the back, yes.
This is more of a clinical quality measure than specifically a quality measure, but I've encountered a lot of patients who don't understand why they need to have cancer staging done, why they need to have their lymph nodes checked. They're going, they did the surgery, they took the cancer out,
Mm-hmm.
they take my lymph nodes out, isn't that going to impair my immune system? How am I going to get better?
Mm-hmm.
So I've heard things like that from patients.
Mm-hmm. Okay. I don't know. I work in primary care. One of the things that we get measured on is patients' blood pressures. So even if the patient's blood pressure is close to the quality measure, and getting it to the quality measure means giving them another medicine and they don't really want it, or they have a relative contraindication to it, then if all you're doing is treating to the test, okay, you might give them a medication that isn't in their best interest necessarily. That would be, I think, hopefully a rare example, but doing blood work, measuring cholesterol panels or A1Cs or things like that, when they're not indicated necessarily for a particular patient, okay? You can always say the patient refuses, but sometimes they're not refusing, you just don't think it's the right thing for them. So what we measure in terms of quality, and remember I said the ACOs, especially the Medicare ACOs, but almost all other kinds of ACOs also, they have to meet some kind of quality standards. So you have to show that your blood pressures and your LDLs and your hospital-acquired infection rates and stuff like that are meeting those standards in order to qualify for some kind of shared savings or bonus or whatever. So that's one challenge to trust in ACOs, is the patient versus organizational interest. Patient and family expectations and experiences is, I think, another challenge. So sometimes patients and families think that somebody's trying to save money, and that can lead to mistrust. A sort of sidebar to this is how physicians are compensated and whether that compensation is itself tied to saving money. Just saving money plus quality, saving money plus something else, I don't know. So patient family experiences and expectations or perceptions about the role in particular of money in clinical decision-making, I think, is a huge challenge for ACOs. Okay. So one thing I think that one of you commented about earlier is that trust in organizations is influenced by, but also influences trust in healthcare professionals or individuals. So in other words, all right, I don't know if these pictures say it right, okay, but on your left is very nice doctor, okay, and very happy patient, all right, and therefore the ACO that very nice doctor works with or in and patient is covered by is judged well by very happy patient, okay? On the other side, you have not so nice doctor, says, I'm the doctor and I'm here to save the world, is what that little script thing says, okay? And not very happy patient, and that patient's experience with that doctor colors their perception of the ACO, okay? Or the organization, whether it's the ACO or a different organization. And it goes the other way too. I think someone, actually, Janice, I think it was you were talking about, if you have good experiences with a particular organization, a hospital or or an insurance company or an ACO or whatever, if you have a good experience there, then chances are you're gonna walk into an encounter with the next person you work with there as a patient with a good feeling, with an expectation, with sort of some baseline trust, if you will, because, oh, they work for Michigan Medicine, okay, or some other organization. So this is bi-directional. I had a hard time illustrating that with my pictures, but I think you get the idea that it goes both ways. Good experiences with clinicians influence trust in an organization. Good experiences in an organization influences trust in the clinicians. Okay. So I talked about challenges to trust in ACOs. What about some opportunities? And I think there are lots of them actually that we can work on that would strengthen and also justify trust in accountable care organizations. One is there is this win-win possibility, right? If you can have better quality at lower cost, who doesn't want that? Raise your hand if you don't want that. Okay? So I think that when you can get better or equal quality at a lower cost, that's a plus. That's an opportunity for strengthening trust and also for demonstrating, if you will, something I think we need to demonstrate, which is sometimes saving money doesn't mean you get less. More is not always better. So if we can demonstrate in a way that's transparent and honest, better or equal care at less cost, that's a plus. That's an opportunity. Planning and management for efficiency, so that's the administrative competence, not just clinical competence, and yet still recognizing individuality of patients. So this is sort of an opportunity and sort of a challenge for ACOs, if you will. You need to give serious weight to patient goals and preferences. There's a sort of movement starting of having medical records, that's electronic medical records, include some kind of sort of patient goal setting, and then to see if those goals are achieved. So in other words, instead of just using like HEDIS quality measures for whole populations of patients, to be able to recognize individuality and individual patient goals and preferences and see whether those are being met is, I think, an opportunity for ACOs. Fostering, maintaining, and strengthening relationships with clinicians, which requires some continuity, time for communication, and communication skills. I have to say, I think the medical profession has been sorely inadequate at making sure that we teach and practice communication the way we should. And this is hugely important to patients, and frankly is kind of the core of our relationships with patients. So I think we as doctors need to do a better job, but I think the organization can also do some things to strengthen communication, strengthen relationships. Organizations, probably more than individuals, can make healthcare a little more patient-friendly, okay? So what about visiting time, right? If any of you ever had a family member in the hospital, raise your hand, okay? Visiting hours, visiting space, it's ridiculous. It is awful. It makes a terrible situation even worse, okay? No individual nurse or doctor can do anything about that, but organizations can. Extending hours, having materials that are more patient-friendly, and the ability to navigate the system being easier. All those things I think are more organizational responsibilities and opportunities to strengthen trust in them. And these are sort of mixed ones, challenges and opportunities, planning and management for efficiency versus the uncertainty of predictions. So in other words, you can pretend that everything's gonna go along this year just the way it did last year, but if you have a flu pandemic, that's not gonna be true, okay? So you need to be prepared. A famous health economist once told me that you always want excess capacity in hospitals and healthcare settings. Always. Which is not the most efficient way to run an organization. But you need it because something bad might happen. Okay? Supporting clinicians' duties of advocacy for patients. So again, the Accountable Care Organization has this responsibility to be administratively efficient, to make sure resources are spent prudently, but they need to recognize that sometimes clinicians have to say, you know, I really think this patient should have this even though it's really expensive. And they need to support that role for clinicians. Seeking and addressing health disparities. Too often healthcare provider entities as well as payer entities pretty much take responsibility for the patients or enrollees they have, which is not necessarily the best way to address health disparities. And community health. Okay, so don't worry, I'm wrapping up soon and then we'll open it up. Yeah.
So in terms of opportunities and challenges,
Uh-huh.
do you have any thoughts on changing Medicare policies such that beneficiaries can also share in the savings?
Love it. I think that, I love the idea. It's something that I've thought of in the past actually, and that is, you know, why not share the savings with not just the provider organization, but the patients they serve. So everybody gets, I mean, you gotta recognize that the more you spread the money, the less anybody gets, okay? But I think there is, and there are ways of doing that that aren't just like writing a check for 27 cents at the end of the year to every enrollee, but instead saying, okay, if we have shared savings, then what we're gonna do is, you know, help provide scholarships at the Y. That might address some of the health disparities too, or something like that. So some kind of community investment or spending that is done because of shared savings. And that recognizes that patients and families and the people served also have a role to play in trying to keep the spending down, right? Did I answer your question? Okay. All right. So yes, I like that idea for an opportunity for ACOs. So what's the evidence show? And there isn't a lot so far, and there's stuff coming out really frequently. So those of you who know more about this than I do, feel free to weigh in. But in a sort of review of evidence about ACO performance, Vocas and Singer said basically it's mixed. that patients, in one study, there was patients receiving care from providers participating in, this is not a Medicare one, but a Blue Cross Blue Shield ACO, experienced better quality and lower spending than a control group. Win-win, okay? We like win-wins, all right? That's good. In another publication, patient assessments, so the patient's perceptions of timeliness, communication between providers, another sort of big deal for patients and a weakness of many systems, was better in ACOs than in matched organizations, and patients with multiple conditions rated improvements in quality after the transition to an ACO. Of the initial 32 Pioneer ACOs, so this is sort of the first ones from Medicare, 18 generated savings, so a little more than half. 25 had lower risk-adjusted readmission rates compared with fee-for-service beneficiaries. So those are all good things. But there's other data that shows less impact, less difference from accountable care. I'm showing you the good stuff, basically. So I'm just going to kind of wrap up by saying that clinicians have, I think, always recognized that we have moral responsibilities in healthcare. But healthcare organizations, I think, also are increasingly recognizing they have moral responsibilities, and that includes accountable care organizations and not just provider organizations. I think the difference, and this is sort of what I was getting to when I was talking earlier about the difference between trust in clinicians and trust in institutions. I think the expectations for advocacy are very strong and should be strong for clinicians. So if you're a doctor or a nurse, your job is to promote the interests of your patient, okay? That doesn't mean you have no other roles or responsibilities, but that is a very prominent one. For institutions, that's much less the case. They're more supposed to be fair. They're supposed to treat people fairly and equally, et cetera, so, or equitably anyway. Clinicians, institutions, both have obligations of beneficence to patients and future patients, and ethics and integrity. As I said earlier, I think expectations for competence on the part of institutions are higher than for, to err as human individual clinicians. So I think patients' expectations, and justifiably so, are that, yeah, people make mistakes. And it's not that institutions can't make mistakes, but they expect more kind of checks and balances on that. Honesty, transparency, and again, fairness. Individual clinicians, it's not that they have no expectations of fairness, but not nearly as strong as they are for institutions who are entrusted with the care of populations and with the stewardship of pooled resources. So I think both are accountable to patients, potential patients, and society, so I just said all this. Okay, so I'd love to have more comments or questions.
I guess I'm struggling a little bit because a lot of organizations, most of them are both ACO and
Yeah.
not ACO. And so I'm trying to figure out how, if they're trying to be essentially both simultaneously, what that does to the structures and processes that you mentioned as important to trust, and then also, so on the organization toward the patient side, whether it actually even matters.
Right.
And then on the patient to organization side, whether they know whether they're interacting with the ACO version of the organization or the non-ACO version of the organization, and how that matters in terms of the trust piece. So can you comment a little bit?
Sure. Yeah, no, it's certainly part of the messiness, because it's not the case that, the accountable care organization, the Medicare accountable care organization here at our institution, for instance, is somehow this sort of separate little world from everything else and everybody else. No, it's part of it. It's part of it. And it's just sort of this population of Medicare beneficiaries who are in this accountable care organization So it's not necessarily the case that the ACO is this sort of unit unto itself, right? And often, in fact, it is built on a reputation and relationships with patients from a different entity, like UMHS or Michigan Medicine, whatever you're calling it, okay? So I think, yeah, that's definitely a messy part. And so then the question is, well, okay, if you're an ACO, but you're also something else, so you're a non-ACO provider of care, for instance, so do you treat patients differently depending on whether they are or are not in that ACO? So that's kind of from the organizational side of things. From the patient side of things, do they recognize, okay, this is an ACO I can trust, for instance, rather than Michigan Medicine and, oh yeah, they sent me this letter that was something about like this ACO shared savings thing from Medicare. I didn't really understand it, but sure, I'm still gonna go there. Okay, so from the patient point of view, they may not see any kind of distinction between the organization as ACO versus the organization they've always gone to as a provider alone, okay? I think recognizing that, sending something in the mail to patients saying that, now we're an accountable care organization taking care of you and you're one of our Medicare beneficiaries and this is what that means, and trying to put that in ordinary language, that a lot of patients are just gonna file that, okay? But I still think you need to explain it a little bit. You need to explain that you're not just a provider anymore, you're also potentially having some financial benefit, or if you're one of the risk-taking ones, financial risk. So I think that needs to happen, even if they file it. And, if ACOs become more widespread, that may be, patients, families, potential patients may become a little more knowledgeable and savvy about that, so. Yeah.
If you go back to that last slide, I was wondering if you could talk a little bit more about your perception of the relationship between trust and these responsibilities, because I actually sort of perceive trust as maybe opposite of what you were saying, that I trust individuals, but not institutions. So I don't trust Michigan Medicine, I trust people at Michigan Medicine. Or, for example, when I worked for the federal government, I had people say to me with some frequency, I trust you to do the right thing. And I always say, no, don't trust me. I don't have control over this. Like, I have to do what you tell me to do. So don't put your trust in me. So I actually sort of see it.
Okay. That's really optimistic.
Well, so that's
Yeah.
the federal government's an outlier.
Yeah.
But I just,
Ugh.
it's just my personal opinion, but I don't trust institutions, so.
So, I would say you probably do trust institutions, actually, to some extent. I mean,
But more than in the individuals that make it up?
well, do you go to a grocery store? Do you know anybody there?
But I'm not eating them, right? I'm like eating the food. Like, no, but I mean, that's not what I'm consuming when I go to
Right,
the grocery
okay.
store. I only buy brands I trust, and sure, I don't know like the people at the organic farms or whatever. So I guess that's an analogy.
Okay, so maybe the grocery store is not a good analogy. Maybe the brand of product is a better analogy. You don't know people there. You trust a brand because of your experience, because of, I don't know, the pictures on it or something, but that's foolish trusting, but which is probably not you. But I think you do trust. I think we do have trust in institutions. I think we more clearly and readily recognize trust in people. That's easier to sort of put our minds around. But I also think that you say, well, I'm going to go here instead of there for my car repair, for my bypass surgery or whatever, in part based on the reputation of the place or what you've heard about it or experienced with it in the past. And that's trust in an organization or an institution, not just in a particular person. So is
Just wondering if you could talk a little bit more about how you're conceptualizing fairness
Right.
marginalized populations. And
Mm-hmm.
I guess if you could speak more to the idea of, is fairness treating everyone the same, or prioritizing those who may not have equity in their lives because of other social determinants of health and things like that. So, if you could just expound a little bit more.
So I think in health care, treating everybody the same is not fair. Definitely, because people have different needs, people have different preferences, people have different contexts, social environments, et cetera. So that's clearly the case. There are whole books written about fairness in healthcare, so I'm not sure that I can just kind of give you a 2-sentence, but equity is, and fairness, I think, is important for organizations, much more so than it is for individuals, because they have to be responsible to a population. You know, what that population is may depend on a variety of things, and they also have responsibilities so in the case of ACOs, let's say you take a Medicare ACO, okay, they have a certain population covered under there. Well, do you have any responsibility also to, you know, other people who maybe don't have any insurance at all, or to addressing social determinants? And I think most organizations actually are increasingly recognizing, yes, they do. How they meet those obligations varies a lot. Okay, and there was one last question in the back row.
Sometimes we have patients and they come in with like mild disease, like mild psoriasis, and they want a biologic, and we don't feel like their disease warrants it, and if they were good about topicals or something else,
Right.
it would be fine. And in that case, I feel like I have to sometimes advocate for the patients, but I don't even necessarily agree with it because there's other people who need that money in the pool more. And like, how can we deal with that, like put in our own opinions, because I just end up stressing the side effects kind of artificially to discourage them.
Okay. I would say you're not alone. And yeah, this is, I think, a challenge for any clinician who takes the responsibility of being an advocate seriously, but also, you know, what a patient wants is not necessarily what they need, and recognizing that you have to work within a constrained budget or environment or whatever that you know, I've had patients requesting a referral to dermatology for a single pimple because they're getting married in 3 months. Like, well, wait 3 months, it'll probably be gone. Or, you know, could I perhaps give you the first line treatment before you go to see the dermatologist? Or, you know, patients, the famous one really is people coming in and they want an MRI for their back pain when in the first 6 months, unless they have some red flags, there's no reason to do that. There's no action that would result. If the patient really wants it, if they perceive you're saying no because of money, which is why you're emphasizing the risks of the biologic instead of the cost of it. If they think you're saying no because of money, then that may undermine their trust. But I would argue that it doesn't necessarily reflect. I would say that it's still, you're being trustworthy. Okay? Remember that sometimes trustworthy behavior doesn't necessarily increase trust in us. So we can talk later if you want. And okay, I got one more. I don't know. Do we have time for one more? We have 2 minutes up there. Yes?
I was a little surprised to not hear more about the dynamic between doctors and the organizations and the trust there. In Lenora O'Neill's Rife Lectures 2002, A Question of Trust, she emphasized the accountability revolution as being what has led to defensive medicine. And how
I'm sorry, has led to the what?
defensive medicine.
Oh.
And that the influence of accountability approaches in documentation and clinical care provision have had real impacts to the negative on the doctor's abilities to connect with patients and things like that.
I'm not sure I can answer that question in the 45 seconds I have left. I would say that, I mean, you touched on a number of issues, including sort of things that organizations do that can promote or hinder good communication and time with patients. We also talked about defensive medicine and, you know, whether that represents some kind of accountability. I'd say, yeah, maybe, maybe not in some ways, but yeah, there's a lot of stuff there. So, but yeah, the relationship between doctors, actually any clinicians, and the accountable care organization, I think is key. But I did talk about that the organization has responsibilities to try to promote, to safeguard relationships with clinicians and the moral aspects of those relationships and the trust in those relationships. So there's a lot of stuff that can be done, I think, to help that. So, okay? Yeah, thanks so much. Thank you.